have an interesting day today ahead of us. I have 3 cases on the operating list. Our first case is 27-year-old who has been suffering with pelvic pain and period pain for a very long period of time. During examination, I was able to find there's a lump in the vagina, quite palpable. Ultrasound scan showed she has an abnormal sliding sign, meaning all structures are stuck together, and with a bilateral endometrioma and also bowel involvement. She then went on to have MRI scan, which confirmed the findings of deep infiltrating endometriosis involving the pelvic side wall, left parametrial area, both ovaries, and rectal muscularis muscle as well. Our case was discussed in our MDT meeting, and it was decided that we should do a joint case. So I'm hoping that my colleague Mr. Valerio Celentano will be joining me and will be carrying out a joint approach. The fundamental principle in these complex endometriosis cases is to manage it conservatively, do it as little as possible, but making sure that we remove all the disease. This helps us not to have an adverse impact on the functionality of any of the organs, be it the ovary, bowel, or the bladder. Our second case is a 44-year-old who also has been suffering with period pains and with a known history of endometriosis for a long period of time. She, during examination, was found to have a left-sided endometrioma along with adenomyosis, also has a left uterosacral ligament thickening as well. So it seems like she has a left-sided significant disease with adenomyosis. She had 2 previous laparoscopies in the past, so she's decided, after considering all the medical options, given that she has tried Marina IUS, Dynagest in the past as well. Her family is complete with 2 children, so she has decided to go ahead with more radical option of doing robotic hysterectomy. We had a long discussion about conservation of the ovaries and decided to conserve the ovaries at this stage, treat the left endometrioma, and carry out a robotic hysterectomy. The important point in this one is that even if robotic hysterectomy is done, it doesn't mean endometriosis will disappear or she will be pain-free completely. Surgical important bit for us is to make sure that even though we are doing a hysterectomy, we have to excise all the endometriosis from the pelvic side wall, treat her left endometrioma with an endometriotic cystectomy, and take the disease out from the left uterosacral ligament. Once we carry out the excision of all the endometriosis along with the hysterectomy, I'm hoping for her to have a much better pain relief with the follow. Our third case is a completely different thing. She is a 32-year-old who is a nulliparous, has been suffering with heavy and irregular bleeding. She was diagnosed to have 9 centimeters intramural fibroid, which is also having an impact on the cavity of the uterus as well. Given the history of 1 miscarriage, it's also possible that this fibroid may have some role to play. Given that she's quite symptomatic now with pressure symptoms, heavy periods, and some degree of fertility as well, we have discussed all the options with her, which was including the medical treatment with transformative acid, sonata, and uterine artery embolization, and she's decided that she would like to go ahead with a myomectomy. So we are carrying out a robotic myomectomy. Robotics now allows us to remove much larger fibroid in very difficult places safely. We use a number of things to stop the bleeding or to reduce the risk of bleeding, such as injection transformative acid, injection vasopressin, doing uterine artery ligation, and even given some time misoprostol as well hormonally. All these 4 steps help us to reduce the risk of bleeding. Given the robotics now again allows us to be quite safe, there's always a very small risk of hysterectomy, but I always say something very rarely to happen. So look forward to this day today, and I'll keep you updated. Thank you.